Hi guys, good evening. Welcome to this fourth module of the IAB Basic Certification course. It's really a proud privilege for me to be hosting this webinar on a very important topic, bronchoscopic biopsies, endobronchial, transbronchial, and I guess cryobiopsy as well, which has now become almost like an integral part of our day-to-day practice. I am Dr. Vivek Nangya, Chief of Pulmonology for Max Healthcare, as well as Vice Chairman and Head for Pulmonary Critical Care, Sleep Disorders, and Interventional Pulmonology at Max Hospital, Saket. So I'll be your host for this evening, and we have a very elegant, very beautiful, very dedicated, committed, and accomplished panel this evening with us, with whom we'll be taking up all our questions. But before that, we'll have a short talk by Dr. Ajay Ravi. Can I have Dr. Ajay Ravi's intro, please, on the slide? And of course, I'd like to thank our academic partners for this entire venture that we are doing this evening, Olympus and Mankind. Mankind, Nitin especially, has been very kind to us and has been helping us with all the various modules. And of course, Olympus has been our long-standing partner and always there for our help. So we have Ajay Ravi with us, who will be taking the talk this evening. He is a consultant interventional pulmonologist at KIMS Trivandrum, honorary consultant pathologist pulmonologist at Regional Cancer Center Trivandrum. And his areas of interest are thoracic radiology, peripheral pulmonary lesions, radial EBUS, thoracic oncology, and that is exactly the reason why we have him here on this topic, because he'll be telling us about step by step how endobronchial biopsies, transbronchial biopsies, and transbronchial lung cryobiopsies are taken. Initially, when we started our practice, there always used to be just a bronchoscopy and BAL, and that's the end of it. But now we realize that even the smaller peripheral nodules can be accessed easily with the help of navigational techniques, with which you can actually get to a diagnosis in no time. In fact, there are recent studies also which are actually talking about moving away from CT guided biopsies to transbronchial biopsies when it comes to diagnosing and identifying cancer. So, there's a recent paper that I'm talking about on how to access the interventional pulmonology part in a lung cancer patient. So we have come a long way with the biopsies. Initially, smaller biopsy forceps, larger biopsy forceps. And when we realized that tissue is the main concern and the size really matters, so we moved on to cryobiopsies, which give you a very good tissue and a greater yield. So I now hand over to Ajay Ravi, who will take us through on step by step on this very procedure. Ajay, all yours.
Thank you, sir, for that kind words of introduction. And let me thank IAB for giving me such an opportunity to present in such a big platform in front of so many delegates. And also, without wasting much time, I think we can go to my presentation. Shall I start sharing my screen? Can you hear me?
Yeah, we can hear you well.
So I hope you can see my presentation. Okay. Okay.
Sir,
So
full
good
screen,
evening.
please. Yeah, yes.
Can you see it now?
Yes.
Yeah. So let's start. So good evening all. I'll be talking about endobronchial biopsies, transbronchial lung biopsies, as well as transbronchial lung biopsies. So I have been told to talk this in 20 minutes. So I won't be going through the much of the indications, contraindications, and all this. So I've been just touching on the topic, as well as how the procedures and step by step how it is being done, and some practical tips how we can go about it, and some all these things. So I'm not this is just a general slides which says that everything has to be individualized. So I think in our panel discussion we'll be going on through all this about sedation, anesthesia, all these things, and all what you want, what you don't want, what you need to be there at your suit. All these things that will be elaborated probably in there. And the indications, contraindications, anticoagulations, when to stop it, how to stop it, what is the limits, all these things. I think we'll go through once the panel discussion progress. So coming to my topic, first topic is endobronchial biopsy. So it is the most common procedure and a pulmonologist do, and it is through a bronchoscope, and it is done for endoscopically visible lesions, which are in the range of an bronchoscopic vision. So we have different types of forceps which we use for this. They can round different types with needle, without needle, round, oval, all these things. So all these have different, but all the way the yield remains same. So you can see this picture. Can you see that? You can see there is a lesion and there is a forceps coming and it is going there and taking a biopsy. Can you see? Can somebody say, just keep this in mind, whether this technique is wrong, whether this technique is right. You can see a forceps coming and going up, taking a bite from a lesion. So you can see there is a considerable distance between the forceps as well as the lesion. So let's progress with about this thing. So just the tips. As you go in, always the thing is that you have to keep the lumen in the center. The darkness or the lumen coming distally should be always on the center of your screen. And if you're going through the nose, don't force in through the nose. You have to find a way and navigate it with very carefully. And if patient has thrombocytopenia, oral route is preferred, not the nasal route. And whenever you use an oral route, you use a bite block, and you should have some assistant to hold the bite block throughout the procedure. And when you use local anesthesia, mostly these endobronchial biopsy procedures are done on conscious sedation. So you have to use local anesthesia, spray more at the cords as well as the bifurcations and to make patient comfortable. And when you try to go in through the posterior commissure, which is the easier way and way to get inside. And when you go inside, you should visualize the normal size first. These are the general things till when you go inside. Now, before that, you should know your instruments. This is your bronchoscope. You can see different types of bronchoscope, and most common thing is that you can see where the working channel is. That is the most important thing when it comes to a biopsy. Where your working channel is, where your camera is, where your light source is. Light source is okay, but your camera and your working channel, this has to be noted. Everybody should know that. This is because where your forceps will be emerging, where your vision is there. If there is some secretion on which side, it can blur your camera. And if the lesion is on which side, it will be easy to take biopsy. All this is different. So this is the right and left. You can see, the working channel as well as the camera here. Okay. So now if you position your scope in a clock position, you can see this lesion. You can see this lesion in almost in the 3 o'clock position, right? And in this case, you can see this lesion is almost in the center, but towards the 9 o'clock maybe. But what is important is that your scope and working channel has a same position, and it goes from your forceps. It will come out through the 3 o'clock position where the working channel is. So according to this, you have to arrange your scope so that your lesion comes on your 3 o'clock position so that your forceps can directly reach the lesion and take a biopsy comfortably. So see this lesion for in the lesion first A. Where is it? It is in another position. You can see it's almost in the middle. And B, it is going towards the 8 o'clock, 9 o'clock position, and the third image, which is coming to a 3 o'clock position. So again, the forceps is coming on the 3 o'clock position only. So you have to adjust. So the technique is that the forceps should open at the tip of the scope always. So it should not go distally and take a biopsy from a distance. It should come from the open at the tip of the nose. It is said that you should take your biopsies under the nose. That's why I showed the initial image wherein the forceps is going too far and taking a biopsy, wherein you won't be having any control on your forceps. But if you see, this is the picture. If you're going too much away, this picture shows it is too far. Okay. So that is not easy. You have to take it close. You withdraw, you open. First, what you do, the forceps comes out like this. Then once you open it, you try to withdraw your forceps a little bit so that it comes close to your scope. And once the forceps is near to the tip of your scope, you move your scope and forceps as a single unit so that you can have control on your forceps. Because if it is pushed distally, there is no control where the end of the forceps goes. But if it is moving as a single unit, you can control and manipulate and take a biopsy from where you want. So Any forceps, again, any forceps can be used, and fenestrated forceps, all this thing that is not going to have much, and hemostatic measures, all this will be discussed during the panel session. So what you have to remember is that um, you have to keep your scope, position your scope in such a position that your lesion comes on the 3 o'clock position of your image. And if you can position the lesion by rotating a scope that the lesion comes on 3 o'clock, you can push the forceps, then withdraw the forceps so that it comes to the tip of the scope, and then push it as a single unit and go in and take a biopsy. And at least 4 to 5 specimens should be used, and additional molecular testing, and you need to take all this additional specimens. And just a practical tip that if it is a necrotic lesion, TBNA also should be done in between so that you get a viable metastatic tissue. Then what are the other and modalities for endobronchial biopsy? You can use a hot cautery reporter, wherein which if it's a vascular aggressive looking lesion, you can take a biopsy, as well as it will cauterize and it won't be having much bleed. Then other thing is the image which you would see, which is called the endobronchial cryobiopsy, wherein you can push in a cryo probe through an endobronchial lesion, and just press the probe and get the probe into the lesion, and you can freeze the probe so that the tumor around the probe also get frozen. As when you take out, you can get a larger chunk of tissue when compared to that. Or you can see the size of the tissue that is coming and compared to a forceps. There is other modalities. So it is an easy, but if you can say that it is an art, and you should have that skill to take a biopsy. It is, if you say EBUS, anyone can do an EBUS, but forceps biopsy, if you want to properly, that's an art. You need practice. You have to have a coordination with your assistant, as well as your working channel. Know about your working channel and take the biopsies under nose. And bleeding complications are usually rare, but you have to be prepared for the worst. Now going to the next topic, that is transbronchial lung biopsy, wherein you take a piece of lung from a distal carina. You can see that picture, a parenchymal lesion beyond the endoscopic visualization, wherein the forceps alone goes distally, and usually it gets wedged into a carina like that, and you take a biopsy from that distal carina, you get the accompanying the parenchyma, and which along with some bronchial wall, and can be taken. So which cases you can get it? So what is it? It is flexible bronchoscopy, but only the flexible forceps which can go through the working channel. So maximum working channel nowadays we have is up to 3. Usual all scopes are 2.8 working channel. So you get the small biopsies. And what is the problem with this? Because we take it for a parenchymal lung disease, interstitial lung disease. So small biopsies may be a constraint, but we can try it for interstitial lung disease of central lobular locations, but some infections like lesions or some miliary lesions like that. But when small biopsies are sufficient for diagnosis, you can go with that. Otherwise, it will not much help. You may have to go for a cryobiopsy. See this picture wherein CT, you can see a peribronchial distribution of the disease, multiple nodules, generalized disease. In these cases, if you go with the transbronchial lung biopsy, then you can have a good yield, because you just need to see some granulomas as in some sarcoidosis or something like that. So in those cases, this will help. But if you want to have a pattern recognition in like an interstitial lung disease and all, the lesion may be too small, wherein the cryobiopsy will pitch in. Now, this is how you take a endobronchial lung biopsy. You go with your bronchoscope and you wedge into a distal airway, where until the bronchoscope goes. You can see that I am in the lower lobe now, and I'm going and I'm wedging my scope. Which segment I need to go? I'm wedging my scope there. Once the scope is wedged, I introduce a forceps, and the forceps will be going blindly. So going blindly till you feel a resistance. So it is not a visual procedure. It is a procedure which has to be felt. It has to be very soft hands. You should feel that resistance. Once you feel that resistance, you withdraw the forceps by a centimeter. Then you tell your assistant to open your forceps, and then you push in to again feel the resistance, and then you take a bite and take it out. You can see the bleeding coming in. So it is usually a procedure which has to be felt. Even you can do it with your eyes closed. That's what our sir used to say, that you can even do it with your eyes closed. You feel it, you feel the resistance, withdraw the forceps by a centimeter and take a biopsy. take a biopsy after feeling again other resistance. You can see the how much the forceps goes. So as I say this, it being a blind procedure, nowadays I never do it as a blind procedure. All my TBLBs are associated, are coupled with fluoroscopy, so that I can visualize where my forceps goes. I'm making sure that it is not going the pleura and making a pneumothorax. Also, I'm making sure that my forceps is opening, which can be visualized in a fluoro screen. So all these things, the fluoro adds to our confidence. Fluoro adds to our yield, because you get many a times when you do a TBLB, you find that your forceps, you take everything done, but when you come out with your forceps, the forceps is not having a tissue. This is because that inside you may not be able, the forceps may not be opening properly because of the small bronchi. In that case, a fluoro will help. You have to agitate a little bit, move it forwards and backwards for some time, so that you can see the forceps opening inside the fluoro, and then you push it, and you feel the resistance, and you make sure that in the fluoro it is not going till the chest wall of the pleura, and take multiple biopsies. And this will reduce the number of fluoro and increase your confidence as when you do biopsies. And also, it also helps you to rule out an immediate pneumothorax after this. So what are the ILDs like sarcoidosis and central ILDs, which are predominantly peribronchial and central lobe, all these things, sarcoidosis, HP, lymphangitis, eosinophilic pneumonias, alveolar proteinosis infection, all this can yield with transbronchial lung biopsies. So as a caution, you won't be doing it in both lungs, because you don't want to get a pneumothorax in both lungs. And the location has to be selected from the HRCT. You are not using a radial EBUS here. And then a larger specimen, if required. If you get if you larger scope, you can use a larger forceps and get a larger specimen. If you use a smaller scope, the working channel is small, forceps is small, and biopsy size is also small. The yield is also less. Again, I'm not going to the limitation as well as safety on this concern. We are going to the last topic of the day, which is the transbronchial lung cryobiopsies, which is more important and being more practiced nowadays, as in it is giving as good yield as a surgical lung biopsy when it comes to an interstitial lung disease diagnosis. So which patients, again, DPLD without a diagnostic after all clinical laboratory and HRT features are combined. And also in UIP pattern, you can do it if there is a clinical reason. Otherwise, a typical UIP pattern does not require a biopsy. Then other patients, the patient should be having a low probability of having an acute exacerbation. That's also important. So now going to the essential investigations, essential as well as desirable. Then contraindications, I'm not going into that. Pathology. So this is important. What is the size of optimal size? And what number of, I think that will come up in the panel discussion. Let's go. So this is important, how to do it, what is the conduit, whether you need to use an artificial airway. So if you have it's always recommended that you should have an artificial airway, because in cryobiopsy, we are coming out with the scope, because the cryoprobe is not coming out through the working channel with the specimen. So we are coming out with the scope. So you need a for scope, you need an airway so that rapid entry and re-entry is possible. And it may not, so that the tracheal wall or the other places where the cryoprobe will not get damaged, as well as if there is a significant bleeding, if the airway is there, you can use multiple things like a Fogarty, all these things to the airway. And whenever possible, and if you are familiar with it is recommended that you go with a rigid bronchoscope, because it has a larger lumen, better control and maneuverability inside the airway, as well as you can have a occlusion balloon like Fogarty catheter when there is a bleeding. So from where to take a biopsy? If it is a generalized disease, prefer to take samples from 2 different lobes. If same lobe is sampled, then you take from different segments, and upper lobes are usually done after getting quiet hands after doing much of the lower lobes. Also try to do it from the middle as well as lower lobes as early as possible. And where to place your cryoprobe? You might have seen this picture. Don't go too peripherally, that red zone, you have more pneumothorax. The inner red zone, it is more larger blood vessel area wherein you can have more bleeding. So the outer brown zone is where the target area where you can take the biopsy, so that there is no much pneumothorax, and bleeding is also reduced. You are not going to the central airways as well. So that is the outer, the brown ring, which is the area where you take the biopsy. So And always it is recommended that you use an occlusion balloon. Fluoroscopic guidance is always recommended whenever it is available, and it is always recommended to use a 1.7 or a 1.9 probe, not the 2.4 probe. And when you are starting with, you start with a freezing time of 3 seconds if you are using a nitrous oxide cryogen, and if it 4 seconds for a carbon dioxide cryogen. And according to, after your first bite, you are using 3 or 4 seconds, you see the size of the tissue coming out. And once the tissue is coming out, if you feel it is very small, you can increase the freezing time up to 6 seconds. And at least 4 tissue samples should be taken, and at least 2 of them should be of adequate size. So now see this video. You can see a rigid bronchoscopic intubation. It is going to the cords. The scope is turning, and then you're intubating. You can see the scope has passed nicely. And once you are inside, it is better that you go to the side, you intubate with your bronchoscope to the side which you are going to take a biopsy from, because this will prevent if you bleed from going to the other side, and you can manage your ventilation well. So this is where you can see first step wherein I am trying a Fogarty balloon. So I place a Fogarty balloon in the target, just above the target segment. I make sure that it is opening and it is covering all this thing, all the target segment. And after that, this is a cryoprobe going in, and now I will be freezing. Once I freeze, I'll be taking out the cryoprobe as well as Fogarty balloon. So the bronchoscope together. You can see the probe and the forceps scope is coming out. And in the same time, my assistant might have inflated the Fogarty balloon. Now I throw it in a saline, and after throwing it, I quickly go inside to see that my Fogarty balloon is inflated, and it is not bleed is not coming out and contaminating the normal lung which you are working. You have to keep the Fogarty balloon at least for 2 to 3 minutes, and after 2 to 3 minutes, you deflate it under vision to make sure that there is no bleed. If you see that on deflating there is bleed is there, you reinflate the balloon and keep it for some more time. So rigid bronchoscope and Fogarty balloon of 5 or 7, 5 to 5, 6 French, or 7, 4, 5 or 6 or 7 French can be used. Then flexible bronch is introduced through the rigid barrel. Then cryoprobe is then passed through the working channel of the flexible bronchoscope. Fogarty is passed through the in parallel. It's passed outside the bronchoscope in parallel to the bronchoscope. It is not through the working channel. On the working channel, you pass the cryoprobe. Once your cryoprobe reaches the periphery, the pleura, you feel the resistance. Alternatively, you will be using the fluoroscope shoe that where it has been reached in the target location. Once you feel the resistance, you withdraw it by 1 centimeter. Then you freeze it. Then you freeze it for 3 to 6 seconds, as I said earlier. Once it is taken out, entire scope with the forceps is taken out, and the occlusion balloon is inflated by an assistant till the bronchoscope is reintroduced after taking the specimen outside. The tip of the probe is immersed in normal saline, and so that the specimen gets separated from the tip. And once the specimen is separated, you introduce the scope, and you go back and visualize, and 2 to 3 minutes you freeze that. And once stored in the normal saline, the specimen has to be immediately transferred into a formalin container. So before starting the procedure, it is important that you check your probe, that keep it in saline and freeze for some time. You make sure that it is nicely freezing and there is some ice forming. Once you confirm that the ice is, you can see the ice forming. Once you on the right hand side, you see in the bronchoscope where I have marked the Fogarty, that is where you can attach your jet ventilation. Through that you can even pass your Fogarty so that it goes in, and through the main working channel you pass the flexible bronchoscope, and then below it's a ventilation port. Now the Fogarty is inflated, and you can check that it is completely occluding that segment. Once you do that, you go with your cryoprobe and take a biopsy and come out. That is how it is. So this image, I think you have again seen. This is how when you see it with the fluoro, you can see that the scope goes here till here. Cryoprobe is going till almost the periphery. And till when you reach the pleura, you withdraw it 1 centimeter so that you check the position. And once you feel it, you enter scope with the probe is taken out. And this is how in the second image, you can see that's how the tissue will look like frozen. And once it is thawed into, this is the size of the tissue. So at least 5 mm size is what is recommended for a specimen. 0.5 mm, sorry, 0.5 mm size. Size is recommended for a specimen to be said as adequate size. So this is the specimen size what you get, and if you can compare, you can see the specimen on the cryoscope specimens are 5 and bigger, and you compare it with the forceps biopsy specimen, which is just maybe 1 or 2 millimeters. So this is the procedure. Once you're done, post procedure, just collect the specimen. You have to get it just a radiograph done, or if you are your fluoroscopy, you can do a fluoroscopy screening. And after 2 hours, also it is recommended to repeat an X-ray to make sure that there is no pneumothorax. After on table, you will extubate the patient, and patient will be shifted to observation unit on oxygen support without an airway, without a ventilator, on a spontaneous ventilation. So you have to have at least 6 hours of observation is what I say, but usually we keep a day for observation and we discharge the patient on the next day. So if the patient has any complications like bleeding or pneumothorax, you may have to deal with an ICD. In bleeding, you may have to deal it on the table itself and get a hemostasis. Then only you can stop the procedure. So that is the basic procedure. I just touch upon how it is being done practically, and this is my team at KIMS Trivandrum, and I thank you all for my patient listening, for your patient listening. Thank you.
Thank you so much, Dr. Ajay Ravi. You were really brilliant in your presentation, I must say. You made it sound so simple. It's such a complex procedure and yet made it sound so simple, truly. I'm sure all of the students who are logged in today would have benefited. So I think now we'll start with our panel discussion. We have lots and lots of things to discuss. Still, there's always something or the other that is, that keeps cropping up in our minds. And I'm sure there would be a lot of questions amongst our audience as well. But before I go on and introduce our panelists this evening, the galaxy of stars that IIB has collected, I think we must collectively thank Dr. Amita for giving us this opportunity to be together and to be discussing such a brilliant topic. I think Amita is the only person in the entire country who's literally carrying the baton of educating each and every pulmonologist on her shoulders. And, the way she has completely revolutionized academics in our country, it's really amazing how it is. So we really thank her and acknowledge all her efforts in doing this. So we'll start with the panelists. So let me introduce the first panelist. We have Dr. Sudhir Tale, who's a consultant clinical and intervention pulmonologist at Medicover Hospital, Vishakhapatnam, has 45 papers to his credit in national and international journals, and has won the All India Second Prize in Sleep Conference at AIMS and the second Best Paper Award in NAPCON.
Thank you, sir.
Next, we have Dr. Ankit Bansal. Can I have the next CV, please? Can somebody wake up? Okay, sir.
Thank you, sir.
So next we have Dr. Ankit Bansal with us. Ankit Bansal is a senior consultant pulmonology critical care at Fortis Hospital, Jaipur. Fortis is the group of hospital that I was working with earlier. So it's really a privilege to have you with us, Ankit.
Thank you, sir. Thank you.
Lovely to hear. Then we have Dr. Vinny Kantru. Vinny Kantru is a colleague from Delhi. She's a senior consultant respiratory critical care specialist, sleep medicine at Indraprastha Apollo Hospital. She's done fellowship from King's College Hospital, NHS Trust, and has won several awards and has many papers to her credit. And finally, we have Dr. Manisha Jain with us. Dr. Manisha is also from Jaipur. She is from the Jain Chest Care Center, consultant pulmonologist, joint secretary of NatCon 2024, member organizing committee TestCon 2024, convener of NAPCon 2025, which was a very lovely conference, and we all attended it and enjoyed it thoroughly, and has been amongst the top 6 finalists in the grand finale of the TISA Pulmonology 2022. She's a live member of various societies, and it's really a proud privilege and honor for me to have such a galaxy of panelists this evening to discuss a very important topic, which can actually be a game changer. Please remember, biopsies these days have become an integral part as a diagnostic armamentarium, as a diagnostic tool. Without that, we really don't move forward. There was a time when people would say that, Doc Saab, if you're doing a biopsy, do you think if it is a tumor, it'll start spreading and that's what we feel. But the answer to them is that if we don't do it, how do you reach a diagnosis? Earlier when you would tell the patients that we need to do a biopsy, the answer, the usual reply they would give is, "Oh, are you suspecting cancer?" No, it's not just for cancer that we do biopsies. We do it even for inflammatory conditions, even for infective conditions. How often we send the endobronchial tissues and the transbronchial tissues, even for cultures, for microbiological diagnosis as well. So biopsies have actually revolutionized pulmonology and intervention pulmonology to a large extent. So let me start with some basic questions and ask Dr. Tale that what are the indications for biopsy during a bronchoscopy, Dr. Tale?
Sir, first indications are mostly for. Hello, I'm audible?
Yes.
Sir, the indications are mainly for diagnosis and staging of the lung cancer. And it is also helpful in diagnosis of some chronic infections like tuberculosis, nocardiosis, and fungal infections. And thirdly, we can diagnose some interstitial lung disease like sarcoidosis, hypersensitivity pneumonitis, and carcinomatosis. And most importantly, nowadays, we can do transbronchial lung biopsy in post-lung transplant patients within the first year to look for any acute rejection and viral infections, etc. So these are the basically 4 most important indications where we perform transbronchial lung biopsy.
So basically what you're saying is that in any patient where you're suspecting an infection, you would do it if you're suspecting an autoimmune disease, inflammatory conditions, and malignancy. Every situation, you do need a transbronchial biopsy to confirm your diagnosis. You can't just leave it at just a bronchoscopic and lavage. So Dr. Ankit, what are the different types of biopsies? Endobronchial, TBB, TBLC, what are these different types and how do they really differ?
Yes, sir. So the most commonly encountered biopsies in our clinical practice, first is the endobronchial lung biopsy, that is EBLB. Basically, it visualizes inside the bronchial lumen technique and generally use forceps, as discussed with my friend Ajay. So basically, this is for diagnosis of endobronchial malignancies, maybe some what is granulomas, sarcoidosis, or benign tumors. The second important type of lung biopsy is a transbronchial lung biopsy, when your forceps passes beyond the bronchial wall into the lung parenchyma. Mostly, it is required for diagnosing conditions like interstitial lung disease, infectious infiltrates, or certain sarcoidosis. Now, the third one, which is now more frequently observed, is a transbronchial lung cryobiopsies, particularly used in the same way as TBLB. But yes, it has a bigger chunk of tissue and with lesser tissue artifacts.
Right. So do you think transbronchial lung cryobiopsy has actually revolutionized our approach to biopsies now?
Sir, definitely, if we have an adequate tissue, it helps us more in easier diagnosis.
Right. So Vinny, what are the relative contraindications or high risk factors for doing a transbronchial biopsy? There would be certain situations where you would say, okay, maybe we hold it back and not do a biopsy. Maybe we'll end up in more complications than giving benefit to the patient because after all, it's a diagnostic procedure.
Definitely. Good evening, everyone. So here we are discussing about biopsies, which we are doing in the lung, and what are the relative and the absolute contraindications. So absolute contraindication would be when the patient has not consented for the procedure. So obviously, you're not going to go ahead with it. There are some uncorrected coagulopathies, which means that the patient has a bleeding tendency or they are on some kind of blood thinners where you are not able to correct their coagulopathy and the patient has a high propensity to bleed intraprocedural. Also, the malignant arrhythmias which the patient might be having and a recent cardiovascular event, which means that a previous MI or a stroke which has happened in the previous 4 weeks at least should not be biopsied so early. They should be allowed their healing time. And there are certain relative contraindications which could be in the form of an uncooperative patient, respiratory failure, where the requirement for your oxygen would be as high as 6 liters. It's especially more than 2 to 3 liter, where you are suspecting that patient, while undergoing the procedure, may have additional hypoxemia, which can risk the life of the patient. And again, there are some certain relative contraindications which could be in the form of uremia, which means in certain CKD patients, we have uremia where there could be platelet dysfunction, where the patient can go on to be having certain kind of bleeding diathesis. So these are some of the relative contraindications. So where we should be very, very careful that patient we are doing this procedure for doesn't land up in complications which have high risk rather than a benefit for the biopsy which we are getting for a particular diagnosis.
So, Vinny, would you like to share with our audience about, if the patient is on ecosprin, what to do, if they're on clopidogrel or on acid chrome, what to do?
Yeah, so
The
there are
different
certain
anticoagulants that we have.
Right, sir. So anticoagulation and antiplatelets are two different agents as far as the antiplatelets are concerned, which is one of them is clopidogrel. It should be ideally be stopped 7 days before the procedure because the propensity to bleed on clopidogrel has been found to be higher in studies when we have compared them to normal controls. Also, if the patient is on double anticoagulation, which certain of the stroke patients might be on, these are also very high risk patients and they should be stopped 7 days before the procedure if you can wait for it. The other ones are patients are on warfarin, which could be in certain of the patients who could be having certain kind of arrhythmias, for example, atrial fibrillation. So 5 days before the procedure, it is recommended that the warfarin should be stopped. The newer NOACs, the newer oral anticoagulant agents have a half-life which ranges between 9 to 24 hours. So 1 to 2 days before the procedure, you should be stopping the newer oral anticoagulants before doing the procedure. And also, if there is a high-risk patient where your patient is on a high propensity to go on to a thrombotic condition, the in-between, the intermittent LMWH should be considered for such patients. They can be put on LMWH as compared to all of these agents, and that LMWH should be stopped 24 hours before the procedure.
Right. So this is very important to know. They also almost form like a relative contraindication, or for delaying the procedure by a day. There's absolutely no harm in delaying the procedure rather than landing up in a complication which you can't handle later. Because if the bleeding starts to happen, then it becomes very difficult to control. So whenever you're doing a bronchoscopic biopsy, you must be prepared for the worst kind of bleeding, I would say, which just happens unknowingly sometimes. Despite all your precautions, the bleeding can go beyond control. So, Dr. Manisha, I'm sure you do this every day, day in, day out. Whenever you're doing a bronchoscopy, you'd prepare the patient, position the patient. So, what are the various pre-procedural considerations that you keep in mind as far as investigations or positioning or anesthesia type and fasting is concerned?
Thank you for the question, sir. Good evening, everyone. Bronchoscopy definitely requires meticulous planning and preparation before performing it. And when we consider, am I audible?
Yes.
Okay. In terms of routine investigations are generally not recommended until and unless there is a clinical picture of increased risk of bleeding, as the patient is on oral anticoagulant, or patient is having any bleeding diathesis, or patient is a known case of chronic kidney or liver disease. Then the complete blood count and coagulation studies become a must. Coming to the position of the patient, so supine position is the preferred position for performing bronchoscopy. And when we talk about the choice of anesthesia, it is still a matter of great debate across the various bronchoscopy societies of the world, because different societies have different views. But if I calculate from the comparative analysis from the various guidelines, I can say that the sedations along with topical anesthesia is the preferred modality of anesthesia for performing bronchoscopy. Sedative agents like midazolam, dexmedetomidine, fentanyl are used, and propofol can be used in the presence of an anesthetist. Topical anesthesia like lignocaine is preferred. For nasal anesthesia, lignocaine jelly we can use, and for the pharyngeal anesthesia, we can go for the lignocaine sprays. When we go for the vocal cord or the tracheal anesthesia, we perform the spray as you go technique, and we can use the lignocaine, or apart from that, we can also go for the transcricoid injection of the local anesthetic. The anesthesia is very important in the planning of performing bronchoscopy because it makes the whole process very, very comfortable both for the patient as well as the proceduralist. Now, when we consider the fasting duration for performing bronchoscopy, we should consider at least 2 hours for the clear liquids and at least 4 hours for lighter meals. So, to summarize, routine investigations are not recommended until and unless the clinical picture is suggestive of increased risk of bleeding. Secondly, supine position is the preferred position for performing the bronchoscopy. Thirdly, sedation along with topical anesthesia. And finally, the fasting 2 hours for clear liquids and 4 hours for lighter meals.
Right. Thank you, Dr. Manisha, for giving us exactly what the books say and what is recommended. But as a good practice, I feel there's no harm in getting a basic CBC, LFT, KFT, and an ECG done because they do give you some idea. What if the patient's hemoglobin is low and you land up in a problem later on? One thing is what the books say and the guidelines say, and the other thing is what you experience in your practical
Definitely.
life, especially if you're doing a procedure like a biopsy and it bleeds later and then the hemoglobin drops down, you wouldn't know whether the hemoglobin has dropped down because of an active bleed or was it low in any case beforehand. So I
Definitely.
think and a
Practically, we hope
basic
for
PT/PTT, there's no harm in doing. So this is like a basic protocol that we should all follow despite whatever the guidelines may say to be safe. These days, in this era of so much of litigation, complications, and everything being attributable to doctors and procedures, especially, that if there's a complication that happened, it happened only after bronchoscopy. If the patient started deteriorating, it happened only after bronchoscopy, while you did it in good interest of the patient. So I think a basic profile like a CBC, LFT, KFT, PT/PTT, and an ECG, there's no harm in doing. And of course, as you rightly said, we combine the two, local anesthesia and a little bit of conscious sedation. Midazolam 2 milligram, 3 milligram is usually sufficient with the fentanyl starting with 12.5, then we keep on adding on to it, going up to 50 to 75 mics. Of course, the books and recommendations may say higher than that, but usually for a simple bronchoscopic biopsy, this is sufficient. But of course, when we talk about transbronchial lung cryobiopsy, then it's a different arena altogether, and that we shall discuss about later on. But I'd like to come back to Dr. Ajay Ravi to tell us about the various equipment that is required when you're performing a biopsy.
Thank you, sir. So as I said in my talk itself, so the basic two things, if you say you need for a basic bronchoscopy biopsy is your bronchoscope as well as a forceps. So which bronchoscope to select, which forceps to select? This is the question now comes. And the other things what you need is for your patient safety once you take the biopsy. Those are the things which for hemostatic measures. So first coming to the bronchoscope, you need a bronchoscope which is working channel. If you're going for an endobronchial biopsy, that means you're taking biopsy from bronchoscopically visible lesions. So endobronchial biopsy, you need a bronchoscope, which is called as a therapeutic bronchoscope with a minimum working channel of 2.8 millimeters size. This is because most of your instruments will go through this. Forceps is large enough, and the biopsy is also large enough. We have different bronchoscopes with different channel sizes, but as far as possible, a larger bronchoscope with a larger working channel is what is preferred. This helps us to get a bigger specimen. Not only that, if it bleeds, the suctioning capacity will be more with the scope with a more bigger channel. And also, if you want to put a Fogarty balloon to put an arrest some bleeding, severe bleeding, or something happens by chance, or if you want to put an APC probe, all this will require a bronchoscope of working channel usually of 2.8. So that is about the scope which is being used. Now coming to the forceps, you can use different types of forceps are available. Oval-shaped forceps, cup-shaped forceps, forceps with needle, without needle, alligator, serrated, all these things. But there has been no direct comparison studies, but none of them has been proved to be superior to the other when compared to when it comes to the yield or when it comes to the bleeding complications. So most of them, whichever is available. But whenever if you have a forceps with needle, sometimes it helps you to have a good position to the mass and it helps in slipping from the mass. But statistically speaking, it is not going to make much difference in the yield. Now the third part of the instruments required is I told is the safety instruments. So when you're doing in a peripheral center where you have just a bronchoscope, what happens if there is if bleeding comes? So minimum things like called saline solution and adrenaline solution, all these things should come in handy. And if you don't have an luxury of an electrocautery or an organ coagulation, at least what you can have is to get a Fogarty balloon, so that if it is not in central main tracheal airway, or if it is even in the main bronchus, you can just inflate the balloon and keep it there so that the bleeding will be arrested. This is the basic requirements which I say will be required for taking an endobronchial biopsy.
Right. So, what is very important is the safety equipment that you must have with you when you're performing a bronchoscopic biopsy, whether it is endobronchial, transbronchial, cryobiopsy. In fact, even otherwise, you should always have the safety equipment back with you. The basic principle is first do no harm to the patient and rest follows on its own. There are times, especially when the patient is coming with hemoptysis and you feel that, it was just a streaky hemoptysis, he says, and you go inside and do the bronchoscopy, there's a whole, it's like a barrage that is opened inside. It's like a dam that you actually unleashed, and the entire airway can get flooded. So you need to be prepared for all these kind of things, even though it all sounds so simple and straightforward, but there are times when you can land up in complications, so you should be prepared for that always. Having said that, Dr. Ankit, there is always, Dr. Tale, I wanted to ask you that, there are always situations where the patient would ask you, you'll have to, apprise the patient that this is what we are expecting. When we go and do a bronchoscopy, we would expect the yield to be this much, you would expect the yield to be that much. So what do you think is the diagnostic yield for different conditions like lung cancer versus ILD? And has the CT quality, the improved CT quality, which ILD would you really do a lung biopsy now, or you don't do it at all now?
So basically, the diagnostic will depends upon whether the disease is diffuse or focal, and whether we are using the real-time guidance like fluoroscopy, and we are using general anesthesia, we are doing under conscious sedation. Because in the disease is focal, if you are using the fluoroscopy, the yield will be up to around 40 to 60%. So in focal disease, if you are not using the fluoroscopy, the yield will come down to around 30 to 35%. So for diffuse lung diseases, the yield, when you use fluoroscopy or not, the yield will be around 70 to 80%. So it mainly depends upon the type of the disease, what real-time guidance, and whether you're using sedation or not. And for these localized diseases, we can take the biopsy from the lower lobes. And in lung cancer, the generalized yield is about 40 to 60%. That's the general, and the yield is different from different studies depending upon what technique are used. And in ILDs, the yield will be more than 75% in specific diseases like sarcoidosis, hypersensitivity pneumonitis, lymphangitis carcinomatosis, and alveolar proteinosis. But by using TBLB, with the chunk of the tissue is very small. Nowadays, for all these ILDs, we are using cryobiopsy to increase the yield. So it depends upon the equipment. So nowadays, with the coming of the new high quality CTs, I usually do biopsies in the patients with indeterminate UIP, and whether we are suspecting any alternative diagnosis, like we are suspecting sarcoidosis, hypersensitivity pneumonitis. Because in this condition, if you give a diagnostic label to the patient, we can adequately treat the patient with immunosuppression, and we can halt the progression and prevent the fibrosis. That's the main fundamental in diagnosing the patients with ILD. So I mainly perform a diagnosis in patient with indeterminate UIP and the patient with alternate diagnosis like sarcoid, hypersensitivity pneumonitis, etc.
Right. So basically, I think the yield will also depend a lot on the site of tumor, whether it's proximal, central, peripheral, where is it? It will depend a lot on that. As far as ILDs are concerned, it would depend whether it's a GGO predominant disease or a fibrosis predominant disease. In a fibrosis predominant disease where the architectural distortion has already taken place, the biopsy may not yield anything much because it would have damaged the lungs already so much that you only get to know that it's a fibrotic disease and nothing more than that, which is evident on the CT itself. And of course, with the newer autoimmune profiles, the CDD profiles, the HP panels that are available, and if you take a good history, then in many ILDs, you may not need a biopsy.
Yeah.
So biopsy in ILDs would probably be needed where you are against the wall, not reaching a diagnosis. And it is more of a diffuse parenchymal lung disease with an alveolar kind of a picture rather than a fibrotic picture.
Okay.
Once fibrosis is set in, then there's very limited utility of doing a biopsy in these situations. Tumors, yes, as I said, and again, it would depend on the size, site, and whether it can be taken CT guided or whether it can be taken from a endobronchially. Just now I saw a patient who had a very good tumor which was almost touching the rib, and the patient underwent first bronchoscopic and biopsy, and while it turned out to be negative, second time they did it within 4 days. They repeated a bronchoscopy and this time did an EBUS as well, but did not think of doing just a CD guide biopsy, which can clinch a better diagnosis. I feel CD guide biopsy gives you a better tissue also. I agree that it's not a part of interventional pulmonology as we talk about, but then you have to be practical towards your patient as well and give them the right option. So, Dr. Ankit, in these situations, how do you really increase the yield in transbronchial biopsy? As I just quoted an example that this patient could not do in the first attempt, they couldn't get anything. In the second attempt, the reports are still awaited. So, what do you think they could have done to improve the yield in such situations?
Definitely, sir. The time you spend more pre-procedure, the smoother the procedure you have, and possibly you have a more good yield. So, as rightly said, that active cuffing dislodge your forceps prematurely. So you need a good sedation so that your forceps is in place. Your patient position is very important because you can go into deeper tissues and have a good chunk of tissue. Beside this, if there is an active bleeding during the procedure, try avoiding taking biopsy at that particular time. HRCT reading is very important before taking a biopsy because if we are taking biopsy for ILDs, we have honeycombing and end-stage fibrosis. Try to avoid biopsies at that particular point. Try to take more from the GGOs and the reticular tissues. Now, beside this, we know that the fluoroscopic guidance has made our job comparatively easier because we can locate the segment from which we have to take the biopsies, avoid the peripheral ones so that the risk of pneumothorax is minimized. So we can be more precisely with our segment that we are dealing with. Now, with certain modalities which is coming up like radial EBUS, if it is combined with, which can differentiate between the eccentric and the concentric lesions, possibly we will have more better yield in that regard.
Right. So basically with radial EBUS, I think it's kind of revolutionized our approach to biopsies. With fluoroscopy, again, it's revolutionized. It gives you the precise location. The limitation of fluoroscopy is that it's still a 2D image.
Yes,
It's not a 3D image, so you really can't access it. But with navigation bronchoscopy, there's further improvement, which can actually real time can actually take you to the exact segment and take biopsies from there. And with it, so you basically, I realize you have to combine all these procedures together:
yes,
radial, navigation, then CT fluoroscopy, and all of that. CBDT. You combine all that, and then you get to a diagnosis. Diagnostic yield is very important. Of course, every center can't afford to have all these tools, but yes, if you look at an ideal situation, combine all of them, and there's nothing that you can ever miss out in the lungs.
yes.
So, Dr. Vinny, something very important is that you've taken a biopsy, you put it in a bottle. Now it is important to send it to the lab. Do you send it in saline? Do you send it in formalin? That's always very confusing. Would you like to educate our audience on that?
Yeah, so the moment we take a biopsy, we think that our job is done, but I think it is at that point in time that it has begun. So what you do is when you take out the biopsies, so ideally you should be doing the biopsies from the affected segment. And if you have a ROSE in your hospital, which is rapid on-site evaluation of your tissue, wherein the pathologist who is there, they just swipe the tissue onto the slide. They see the slide if the tissue is showing some kind of picture, for example, some carcinomatous cells. So that would give you an indication that you have got clinched a diagnosis, and you may not be taking further tissue chunks, which in this case, it may be 2 to 3 pieces, which will be adequate, and you will be preventing your patient from further complications, which could be in the form of bleeding and pneumothorax, which are the most common complications which we encounter. But the minimum number of pieces, which is recommended in guidelines, as well as seen to be having maximum yield up to 96%, is 5 to 6 pieces. If you are considering sending your tissue for molecular diagnosis, then one additional piece will be required, which ideally has to be frozen in liquid nitrogen. However, this may not be present in every center. You can actually send it in buffered 10% formalin solution, which is the normal usual solution which we use for our biopsy pieces. Now, another consideration, especially in our country and also with setting in of lung transplant, wherein we are also looking at the infections which may set in. So we also send our biopsy pieces for the molecular, the microbiological analysis, because that is something wherein we put our tissues for the gene expert for tuberculosis, as well as for the AFB analysis and fungal infections, which are very, very common in post-transplant patients. So for these kind of patients, you have to be sure that you are keeping these biopsy chunks in normal saline and do not put any kind of formalin into this solution, because that is going to kill your microbiota. So that is how you have to take care of your samples, and also do not agitate the tissue too much so that there is architectural distortion in these very, very fragile kind of tissue pieces which you have taken out with so much of difficulty.
Right. So, what is very important is that you're doing a biopsy, and this biopsy has to be complete in every aspect. It is not just a diagnosis, but if you're dealing with a cancer kind of a situation, then you would require a larger sample for doing this new gene sequencing that has now become almost mandatory for every patient for guiding their treatment. So it is very important to get adequate tissue. So 4 to 6 samples is something that you should be looking at, and another sample only for microbiological cultures. Even if it is, even when you're taking a cryobiopsy, what we do is after taking the cryobiopsy, we take another biopsy with the conventional transbronchial biopsy forceps and send that for microbiological examination, because cryo tissue cannot be sent as it is frozen already. I still remember we had a patient who had multiple patchy opacities in the lungs. And twice or thrice, I think we did it, or maybe just once. Yeah, twice or thrice we did his bronchoscopy. BAL was negative. But every time we send the tissue for culture, it would grow something or the other. So BAL being negative, tissue being positive, that would definitely give us a confirmed kind of a diagnosis that yes. And even if you see aspergillus, the diagnosis of invasive pulmonary aspergillosis can only be made on a biopsy if we look at a classical diagnosis. Rest of the situations is probable IPA that we treat always. And just presence of aspergillus in BAL does not actually mean that this is invasive pulmonary aspergillosis. We may consider it and treat it that way, but it actually does not mean unless there's a biopsy proven. So
Also, the sample should be sent to the lab as soon as possible. So do not delay it. If you're anticipating a delay, please keep it refrigerated at 4 degrees C. So that is something which is very, very important.
So handling the sample is very, very important. So, Dr. Manisha, Ajay told us that do an endobronchial biopsy, you put in a scope, take the biopsy forceps into it, open it up and wedge it and pull out the tissue. It all sounds simple. But what do you think can be the potential complications of endobronchial biopsies, and how would you manage them really?
Endobronchial biopsies are generally safe, but definitely there are several complications that can occur, which are directly related to the biopsy sampling itself or to the procedure as a whole. So the probable complications that can occur are the most common one being the bleeding. Less common are pneumothorax, and there can be mechanical complications like trauma while negotiating the scope, trauma to the anatomic structures, then anesthesia-related complications, or there can be introduction or flaring up of infections, or there can be desaturation, hypoxemia, etc. When we come to the management part of these complications, I would like to focus mainly on the complications and the management which are directly related to the endobronchial biopsy, that is being the bleeding, which is a very common, very important and directly related to the endobronchial biopsy sampling. Mild bleeding can just be managed with simple suctioning, and these are usually self-limited, but when there is moderate bleeding during the endobronchial biopsy, it requires attention. Apart from suctioning, it requires instillation of cold saline or topical vasoconstrictors like epinephrine, or we might also require tranexamic acid to be instilled into the lesion. Apart from that, the bronchoscope can be wedged into the bleeding segment so the tamponade is maintained and the bleeding stops. However, if unfortunately severe uncontrollable bleeding occurs, then we need to rush and we need to protect the other lung by putting the bleeding lung into the lateral decubitus position so that the other lung is protected. Apart from that, continuous suctioning, and we might have to use endobronchial blockers, and due to extensive bleeding, the APCs and the cautery should be kept handy, and we need to convert the procedure into a rigid one. And the severe bleeding actually requires utmost attention, because apart from managing the bleeding and stopping it, the hemodynamic stability of the patient should be kept in mind, and the airway patency is very, very important to be maintained. Apart from this, the bleeding being the most common complication, the less common like pneumothorax can also occur, very rarely though. In case if it occurs, small pneumothorax, and when the patient is entirely asymptomatic, we can just relax, and a patient can be sent for bed rest, oxygen therapy, and we can just observe. But however, if there is larger pneumothorax occurs due to post biopsy, then we need to put the chest drain, and more vigorous monitoring is required.
So yeah,
So
you're absolutely right. Usually when you do an endobronchial biopsy, the bleeding is usually not as much because it's just the mucosa that you're picking up and not anything more than that, unless there's a tumor or something there or a very vascular mucosa that starts to bleed. But of course, as I said in the beginning, also bleeding is something that you need to be very, very careful of. Pneumothorax you can still manage unless it's a tension pneumothorax on the spot where the patient is going into an acute respiratory arrest kind of a situation. But otherwise, and in that situation, I feel you don't even need to wait for an X-ray. Even if you have to empirically put in a needle or a tube to release that pneumothorax, there's no harm at all.
definitely,
But
sir.
bleeding is something that can be life-threatening and can actually be very, very challenging sometimes. So use of cold saline, use of so now they don't recommend using ADR that we still use sometimes, that add ADR to cold saline and then see. But what is very important is that you just tamponade that area from where the bleeding is coming. Whether it is a segmental bleed or a mucosal bleed, you have to tamponade it with something or the other. So whether you use a balloon or whether you use the bronchoscope itself to tamponade that area, that's very essential. And then, of course, comes the isolation of the lung, prevention of the other lung, and so on and so forth. So, Dr. Ajay Ravi, I wanted to ask you that, what are the key differences in performing endobronchial biopsies in adults and in pediatrics? Are there any, or is it just the same?
That's a very important question because who are venturing into bronchoscopy and biopsies. So first thing I would like to say is that there is a key difference is that pediatric bronchoscopic biopsies are almost always being done under general anesthesia, and you will be having an airway. This is because the kids they won't be cooperating as expected, and so it is always usually done under GA as with an airway in situ. So, and whenever somebody is planning to take a biopsy from a pediatric patient, you should be sufficiently experienced with the adult patients' biopsy procedures as well as all hemostatic measures. Here, because the importance is that already the airway is small and you are having an artificial airway in situ, and your bronchoscope has to go through the artificial airway into the child's airway and take a biopsy. So the scope will be smaller size, working channel will be smaller size, forceps will be smaller size, your suctioning capacity will be lesser. The instruments which are passing through the scope will be smaller, will be very less. Your hemostatic APCs may not be unless you have a pediatric probe and all. All this or a FOGAT may not even pass. So all these things may be limited. Your options are limited. So you have to be prepared. You have to have you all set off your pediatric instruments, the pediatric sizes of all the adult things which you have, because once a complication or something sets in, then you are not going to search for this. So you have to be prepared with all your safety equipments. And you have to understand your limitations, that these things have not, some of your things which are you used to may not be going to work here. And because being the forceps being smaller size, you may have to take more biopsies. more number of biopsies. And again, before the procedure, you have to have a good word with the parents. Your consent is very important. You have to mention not just the bronchoscopic biopsy-related complications, but also the anesthesia-related complications. Because most of the situations, it is not our biopsy or not a bronchoscopy which causes confusion after the procedure. Sometimes the child's anesthesia, coming out of the anesthesia, hypoxia after the anesthesia, all these things may lead to some prolonged ventilation, maybe a delayed extubation. All this thing has to be well communicated to the parents and well documented, and the proper consent informed should be taken. First of all, it is the technique wise, it is the same. And again, selecting the size of the scope also is important. So if you are using, you will be using an airway, you should have a good rapport with your anesthetist. What is the airway they are going to use, whether it's a supraglottic airway like a laryngeal mask airway, or an IGL which is more comfortable, or an endobronchial and the endotracheal tube, or even a pediatric rigid bronchoscope. This has to be confirmed, and the size of this scopes has to be confirmed, and which bronchoscope will go to your in that particular artificial airway. So if you're using an ET tube, it is recommended that if you're sizing up using a pediatric scope, which is 4 millimeters of outer diameter, at least 1.5 extra, that is at least 5.5 or 6 size of ET tube is required, so that ventilation is also being carried out while you do with the bronchoscope or with the bronchoscope. So they recommend at least 2 size above that. If you are using 4 mm scope, 6 ET tube at least is what they recommend, but at least it should be 5.5 so that ventilation is not affected. This is so you should make sure that for the particular child you have the scope, either ultra thin scope or an ultra thin scope as required. These are the main things which you have to take care of. Procedure wise and technique wise, it is almost the same.
Right. So, Dr. Tale, we've been talking about bleeding and pneumothorax as 2 potential complications which are seen. In fact, those are the 2 most common complications that you would see. And you would always, tell the family that this is what is expected. So, I mean, this can happen. We should be prepared for it. But, just for educating our audience, that how do you think we can minimize the risk of pneumothorax? And when would you perform a chest X-ray after biopsy? Immediately or a few hours later? Dr. Tale, you'll need to unmute yourself, please.
Sir, we can prevent the development of pneumothorax by 3 steps. The first one is the meticulous pre-procedure planning. Like we have to do proper patient selection. We have to be careful while performing biopsy in patients with COPD. And the first, if there is availability of some image guidance like fluoroscopy, we should always use, because it prevents the puncturing of the visceral pleura and we can prevent the pneumothorax. And the third point is always take the biopsy. During biopsy, we should use techniques like the breathing maneuvers, and discussed by Dr. Ajay Ravi. We should push the forceps and retract back by around 1.5 to 2 centimeters, and we have again push the forceps 1 centimeter and take biopsy. If the patient is complaining of the pain, we should immediately open the forceps. We should not take the biopsy. And we should, while taking the biopsy, it's always important to tell the patient in conscious sedation to hold the breath in expiration. And post-procedure, we can tell them to put the patient in lateral position, biopsy side down, so that if there is small puncture leak, the gravity opposes the parietal and visceral pleura, and further it prevents the development of pneumothorax. So these are the 3 steps which we follow carefully. We can prevent the development of pneumothorax. So coming to the X-ray, according to the guidelines, in asymptomatic patient, it is not necessary. But in my practice, we generally do X-ray after the transbronchial lung biopsy. And generally, we will do after 1 to 1.5 hours of the procedure to see if there is any pneumothorax or not. If the patient is sick after taking the biopsy, without, as we discussed by you, we can blindly put the needle or tube if there is high probability of the pneumothorax.
Absolutely right. So I think one very important message that Dr. Tale has brought out is that if when you're doing a bronchoscopic transbronchial biopsy and patient shrieks in pain, please leave the tissue there, open up the forceps and withdraw the forceps, because that actually means that you've caught the pleura there. Pleura is the only sensitive organ, pain-sensitive tissue in the lung. So if the patient is shrieking or even wincing in pain, that means you've touched the pleura, withdraw the biopsy forceps, do not bite there. So, Dr. Ankit, we've been hearing about transbronchial cryobiopsy, which has actually revolutionized our approach, gives us better tissue and everything. So, but what is the principle? What does it actually work on?
So, sir, basically, transbronchial lung cryobiopsy is a bronchoscopic technique in which a cryoprobe is used to obtain a larger and a better preserved lung tissue sample from the lung parenchyma. So, there's a cryogenic principle, that is, you rapidly freeze off tissue using extremely low temperature. If we see the physics, it is basically using the Joule-Thomson effect. Possibly when a compressed air like carbon dioxide or nitrogen dioxide rapidly expands at the probe tip, the temperature drops down suddenly. And this drop of temperature generally causes to the lung tissue to get freezed. And this is the fundamental thermodynamic principle behind the cryoprobe. Now, there is cryoadhesion. That means the frozen tissue which we have done, it stick to the probe. There is no mechanical cutting needed. And you extract a large, possibly artifact-free specimen. And your tissue is relatively preserved. So you have an advantage of larger samples, better histopathological accuracy, and higher diagnostic yield with lesser crushed artifact in that particular sample.
Right. So, Dr. Vinny, of course, we know the yield is much higher with the transbronchial, but would you just like to review the steps of doing the procedure once again, please?
So
Maybe
primarily,
you give us a different perspective than to what Dr. Ajay has already given.
yeah, so he has very well enumerated the steps which are required for transbronchial lung cryobiopsy. So primarily, we have to understand that this procedure has to be done under sedation, and preferably an anesthetist would be required during the procedure, because this is comparatively a deeper sedation where your patient should not be coughing a lot, as the chances of shear forces causing the bleeding are more. So artificial airway is also required. This artificial airway, initially, when you're a novice, you should be starting with a rigid scope, because that has more control over your processes during the bronchoscopy. However, if you have done about 50 number of procedures, 25 to 50, then you can shift on to the endotracheal tube, wherein you can control the amount of shear forces by then. So in our center, what we do is that we do it with an ET tube. So primarily, we put the Fogarty catheter outside the ET tube. So first, with the bronchoscopic guidance, with the thread of the Fogarty catheter pitched onto the bronchoscope, we go into the segment of interest, and we put and park our catheter in the adjacent segment, which was shown very nicely by Dr. Ajay. So after that, we put in the endotracheal tube, we intubate the patient, and after this, we after adequate sedation, we preferably keep the bulb of the endotracheal tube deflated so that there is not much coughing during the procedure. The coughing has to be prevented. With this, in the bronchoscopic channel, we put in the 1.9 mm cryoprobe, for which the principle was just now discussed. After this, the steps of the procedural steps which are followed are exactly similar to what we do in a conventional transbronchial lung biopsy. We go into the area of interest, we feel the maximum area of resistance, we withdraw the probe by 1 centimeter, and then we put the paddle on for about 4 to 5 seconds. Initially, you might try with 3 to 4 seconds only, because the more freezing there would be, the more shear forces would be accompanied with it, causing more number of bleeding. So what you have to do, once you have wedged your scope as well as the cryoprobe, you have frozen it for 4 to 5 seconds, you have to pull and withdraw both the cryoprobe as well as your bronchoscope simultaneously out of the ET tube, while one of your assistant is holding the ET tube in place. So once this tissue and the cryoprobe with the cryoprobe is out of your patient, you put in this, you thaw this tissue into the normal saline and get your pieces out. While you are doing this in and out procedure, an assistant, a dedicated assistant is there to inflate the balloon into the adjacent segment so that the bleeding which has happened there is not spilled over into the adjacent segment, causing the hypoxemia, which is very well documented in patients wherein we do the TBLC procedure, because it is this procedure which is causing the shearing forces leading on to the bleeding. So you keep this Fogarty catheter inflated for about 2 to 3 minutes minimum. You immediately go in with your bronchoscope again to visualize the area. Slowly deflate the balloon and see if there is not a gush of blood coming out. If there is still bleeding coming out, you inflate the balloon and come out and keep inflating the balloon so that the bleeding is controlled. Now, if the bleeding is controlled, you take your subsequent pieces out of the lung in a similar manner. So that is how we do a cryobiopsy. And it is almost similar to what we do in a conventional biopsy. However, you have to take the considerations in mind that this is a procedure which is going to give you a bigger chunk of tissue. There would be more shearing forces. There can be more bleeding. So your crash cart should be present in your bronchoscopy suite at all times.
Absolutely right. So, over a period of time, our anesthetists have got trained to put in the balloon for us. So now we don't even need to do it with the bronchoscope. They already put the balloon. So after giving a little bit of the propofol sedation, they introduce the balloon also inside. They actually blindly are able to put it right into the trachea, and then with the bronchoscope, we actually direct it into the left or the right side wherever it's needed and take it to the desired segment. So after that, the patient is intubated, and then you do the biopsy. So it is not something that one person alone can handle it. There has to be, as Dr. Vinny said, there has to be one person who's handling the ET tube for you. There's another person who's handling the balloon for you. There's somebody who's got the cryoprobe ready for you, and you're just pressing the paddle so that you're only for 4 or 5 seconds, and then pulling it out. While pulling it out, also sometimes the tissue slips from that probe. So what you do is, after having pulled the tissue out, then again keep pressing the paddle intermittently, so that because of the cold effect, it remains stuck to the probe. Otherwise, you can just lose the tissue which you've pulled out. You've harmed the patient and not also retrieved adequate tissue. So, these are just simple tips that you need to remember. And bleeding is really very major sometimes and can be very, very dangerous. So balloon should be in place. You should have tested the balloon before you started the procedure. That balloon is inflating, is not, punctured or anything, and is of the right size to be able to block the entire lumen. So you need to be prepared for all that. So, Dr. Manisha, there was some time back, there was this paper called the Cold Ice Study from Australia. So would you like to tell us about that, please?
Yes, sure, sir. The cold ice trial was a multi-center study which was done, as you rightly said, in Australia. And it was done to compare the diagnostic accuracy between the transbronchial lung cryobiopsy with the surgical lung biopsy. I would just highlight the main interpretation of the study. It was found that the results of the transbronchial lung cryobiopsy and that of the surgical lung biopsy.
In what subset of patients was this?
It was done in patients of ILD. In interstitial lung disease patients, it was done. And when the results were compared, it was found that there was a strong concordance between the results obtained from the transbronchial cryobiopsy when compared with the surgical lung biopsy, both in terms of histopathological examination as well as the MDD diagnosis. And hence, in that study, it was very well highlighted that transbronchial lung cryobiopsy could be a reliable alternative to the surgical lung biopsy, which is comparatively very safe than the surgical lung biopsy, of course.
So what you're saying is that you no longer need a surgical lung biopsy. With the advent of transbronchial lung cryobiopsy, you're able to get most of the diagnosis. And in fact, the yield is almost equivalent to a surgical lung biopsy. So you basically made a thoracic surgeon jobless now. But please don't ever...
No. I would just like to intervene here that I'm not telling that surgical lung biopsy is obsolete now, but however, it is now reserved for only such cases where the transbronchial lung cryobiopsy could not give us conclusive results. So surgical lung biopsy is still in the race.
But this study actually showed that the yield is almost similar of both the biopsies, whether it is TBLC or surgical lung biopsy. And I feel when it's a fibrotic disease already, then it really doesn't matter. And it's not really advisable to go in for a biopsy at that stage, because
Yes.
even if you, I mean, if the patient lands up with a pneumothorax in a fibrotic lung, healing that pneumothorax can actually be a
Cumbersome.
uphill task, quite an ordeal.
Yeah.
So there are situations where you need to be a little careful. You need not necessarily follow what the Western world says and what the advanced developed countries follow. You have to, I feel, adjust the situation according to your own circumstances. So,
Definitely.
Dr. Ajay, coming back to you, that you TBLC. So, how many samples would you need? 4, 6, 8, one lobe, two lobe, three lobes, and what is the use of imprint cytology?
Yeah. So again, a very important question, because we are doing a invasive procedure, usually mostly under with an airway general anesthesia, that too a diagnostic procedure, not a therapeutic procedure. So we need to get the diagnosis. We are very much answerable. Such and it's not just like a bronchoscopy being done under conscious sedation. So we need to get a diagnosis. So what the recommendations say is that you need to take at least 4 specimens, 4 samples. So as I said earlier in my talk, if it is a generalized lung disease, it's preferable to take it from the lower lobes. And if it is possible, take it from 2 different lobes, maybe middle and lower lobes. And if you are taking from a single lobe, take it from 2 different segments. So like that, it is how it goes. And upper lobe is least preferred. And with sufficient experience, you can even try from the upper lobes also. Now, 4 samples is what is being recommended to get an adequate yield and to maintain the safety. So what they say is that more than 4 samples, the safe yield is not much improving, but the number of biopsies and the complications may increase. So 4 sample is considered as adequate, and out of this 4 samples you take, at least 2 of them should be of adequate size. That is what they say. So to adequate size means what they say is a 5 millimeter, as I said in my earlier talk, 5 millimeter size is said to be an adequate size of a cryobiopsy specimen. Why this is 5 millimeter? This 5 millimeters corresponds to the field of area of a 4x microscope zoom. So if you keep it in a 4x microscope zoom, the area it covers is approximately 5 millimeters. So this will give us help the pattern recognition in case of interstitial lung disease, because you are not going to see the individual fields, small fields. So pattern recognition is also very important when it comes to the ILD, interstitial lung disease. That is about the size and number of specimens. Now coming to the second part of the question, which was asked, was about the imprint cytology. So, well, I would say that we usually don't do that. And the very purpose of getting a transbronchial lung cryobiopsy is to get a larger specimen with a tissue integrity and to know about interstitial lung disease. So imprint cytology usually may not be of that helpful in a specimen in a procedure like transbronchial lung cryobiopsy, unless we are suspecting something like a malignancy or something like that, where you can directly get a or even a tuberculosis, something where you can appreciate some granulomas. For interstitial lung disease, usually transbronchial lung biopsy, even a forceps biopsy we say is insufficient. So imprint may not be of that help because of the subset of patient we are sampling.
Right. So, Dr. Tale, are there, in situations like sarcoidosis, hypersensitivity pneumonitis, are there any specific techniques for sampling different lobes, especially the upper lobes?
So basically, the sampling of the upper lobes is relatively challenging because of the acute angulation with the airways and the narrow diameter of the airways. So for this, there are different tricks and techniques. For example, if the angulation is difficult, recently a paper by Ravindra Mehta sir, where we can use a extended biopsy channel technique, where we can use a radial EBS guide sheet and we can pass the forceps and take the biopsy. Or you can use a fluoroscopic guidance so that we can take biopsy from the exact location and increase the yield. So for coming to sarcoidosis and hypersensitivity pneumonitis, generally in sarcoidosis, along with transbronchial lung biopsy, we will do endobronchial biopsy. So we can increase the yield of the diagnosis. And in hypersensitivity, before doing a biopsy, a good CT scan is essential because we have to see from which area we have to take the biopsy. We should take the area biopsy from the area which is having inflammation, like ground glass opacities, and we avoid taking the biopsy from the fibrotic areas. So because we don't get any diagnosis, so we have to take a good CT scan before proceeding for any ILDs to get the maximum yield.
So basically, I feel in my practice, what we've seen is that there are only 2 segments which are difficult to access: the apical segment on the right upper lobe and the apico-posterior segment, which is the most challenging on the left upper lobe. In fact, apical segment right upper lobe is also not so difficult. It's the apico-posterior on the left side, which is always a challenge. So in that situation, what we usually do is you first introduce the scope into the segment itself and then push the biopsy forceps inside. Rather than keeping the scope outside and then trying to manipulate the biopsy forceps inside, it usually slips out. Or else what we do is then we use a pediatric scope and do a pediatric bronchoscopic biopsy forceps as well, and then get the tissue. So that is the only way you can reach there. But yes, it can be challenging. So Dr. Ankit, how would you manage a bleeding, especially whether it's TBLB or TBLC? Bleeding is always very, very challenging, and we've been talking about it right from the beginning. And Dr. Manisha did mention a few tips also about managing it. Would you like to elaborate on how to manage the bleeding in these situations?
Yes, sir. Sir, for any kind of diagnostic modality, life-threatening emergencies are totally not acceptable. So if you prepare yourself well before the procedure, I think you can have a smooth procedural workup. So in that, the workup is very important. Again, we can't forget our basics. Look for the platelet count, look for the INRs. If there is an antiplatelet and anticoagulation, stop appropriately before doing a procedure. Try to avoid the major blood vessels. Go for the peripheral lesions if you are taking any transbronchial samples. Now, particularly in transbronchial lung biopsy, cryobiopsies, we can use bronchial Fogarty catheters beforehand before doing the procedures and when you take actual biopsies. So we cannot forget the immediate management that is important, which we have been traditionally doing for stopping any kind of bleeding, which is wedging of your scope at the biopsy segment. The controlled suction is important. Installation of cold salines, which can be done into 4 to 8 ml liquids up to 20 to 40 ml. You can use vasoconstrictions like adrenaline into 1 to 2 ml liquids. Alternatives could be tranexamic acid. But yes, in case of moderate to severe bleeding, balloon tamponade is a very important thing in that particular case. So the Fogarty balloon catheter, which is inflated at least for 2 to 3 minutes, will help you a lot in that particular case. You can instill the endobronchial blocker that could help you out in that case. But if you have a massive bleeding and patient is flooded with blood in the major bronchus and there is hypoxia, you should not wait for delaying your intubation and ventilation. That is very important. And just to secure the bleeding in that particular case. So in most of the cases, rigid bronchoscopy is really a help in that sort of things. Again, if still the bleeding is not controlled, you can always search for the options of advanced measures. Selective, what we call as bronchial artery embolization could be done. And you should have your surgical friends handy at your place if still bleeding is not controlled for any kind of surgical intervention.
Right. So I think first and foremost, when you're doing a transbronchial biopsy and patient starts to bleed, in fact, even before that, what is important is when you're doing a transbronchial biopsy, you've pinched and taken the tissue out. It should be a spontaneous reflex that when you're pulling the biopsy forceps outside, you should be pushing the bronchoscope inside so that you do not ever lose vision of the segment from where you've taken a biopsy, nor should you ever lose the scope out of the segment from where you've taken the biopsy. If you do that, that is blunderous. You are doing a bronchoscopic biopsy, you pull out the biopsy forceps and you pull out the scope also from there. Bleeding starts to happen. You've lost the segment. You will not be able to control it then. So what you do is, as a principle, when you do a biopsy, you pull out the biopsy forceps, push the bronchoscope into the same segment and tamponade it there for 3 to 4 minutes. Don't even look at it for the next 3 to 4 minutes. The bleeding automatically will stop. If it continues, then your first reaction is to put an ice cold saline. Ice cold saline should be at about 3 to 4 degrees temperature, and you can actually feel it going through the bronchoscope. When you're holding the bronchoscope at its tip, you can feel the cold saline inside because the temperature outside also changes. If that doesn't help, then you put the patient in the bleeding side downwards position. Use an ART blocker to block it, or a Fogarty, or there's a uni blocker also that's available that can be inserted through the bronchoscope itself to block it. And if that also doesn't help, then of course, bronchial artery embolization is your final rescue. So you have to be prepared for all this. So Dr. Vinny, so, of course, we realize that bleeding is a very important complication. We were discussing about the various medication also. But what about the cardiac comorbidities? What precautions do you take in cardiac patients?
Yeah, so this is something which we quite commonly encounter in our patients, because most of the patients, we are a diabetic capital of the world, so they have cardiovascular complications. As I said before, if they have malignant arrhythmia, which is uncontrolled, you should not be taking up that patient. It's an absolute contraindication. And if they have certain anticoagulant agents or antiplatelet agents that has been discussed already. Now, patients who have had a recent MI, which means ideally they should not be going in for the procedure for 3 months. They should be given that safe period of 3 months for undergoing any procedure through the bronchoscope. However, if your procedure is something like a BAL, you can take the BAL, but biopsy should be avoided. So, any unstable angina is also something you should be taking care about, because the patient can go into arrest on table. So that is something which you have to consider when the cardiovascular risk is there in your kind of patients. So other than that, as we already discussed, if there is uncontrolled atrial fibrillation, that has to be controlled before the procedure. If the patient is having congestive cardiac failure, that should be sorted out first, rather than going in with the scope and causing further damage by causing the additional hypoxemia, which these patients might be subjected to. So arrhythmias, congestive cardiac failure, recent MIs, these should be considered when you are taking care about your cardiac comorbidities.
So recent MI for how long, Dr. Vinny?
Ideally 3 months, but 4 weeks is something which, if your procedure is absolutely essential, after 4 weeks you can go ahead with the procedure. But if your procedure can wait, 3 months is ideal.
Right. So, Dr. Manisha, we were also talking about anticoagulants. Can you please tell us again about, how do you prepare your patients if the patient is on anticoagulants?
Definitely, sir. In the first part, I would just be repeating what Dr. Vinny has already mentioned about the anticoagulant treatment and when to stop what. So basically, when the patients are on anticoagulant therapy, meticulous planning is required, and we should stop the anticoagulants like warfarin at least 5 days prior to the procedure, and we should ensure that uh, INR of less than 1.5 is maintained. Apart from that, the newer oral anticoagulant agents can be stopped 2 days prior as per the guidelines. And when we talk about the antiplatelet therapies, recently it has been recommended that low dose aspirin can be continued for the procedure. However, other antiplatelet agents like prasugrel, clopidogrel, ticagrelor, they need to be stopped at least 5 to 7 days pre-procedure. And to maintain safety, INR less than 1.5 should be maintained, and the platelet count of at least 20,000 requires for taking BAL and at least 50,000 for taking the biopsies. Apart from that, the bleeding risk is there definitely on for the patients on anticoagulants, but we have to also weigh the risk of the thromboembolic effects. So the bridging therapy with low molecular weight heparin is also a very important aspect when the patient is on anticoagulants. And the bridging therapy with LMWH, it can be started 2 days after stopping warfarin, and it can be continued the night before, that is 24 hours before the procedure to be taken. Apart from that, in the patients who are having increased risk of bleeding, we can take some small steps like minimizing the procedural trauma to the structures, or we can just use the image guidance for taking the biopsy so that unnecessary passes can be avoided and bleeding risk can be minimized. Apart from that, there is intratumoral injection of tranexamic acid can also be used. It is a technique which is recommended if there is endobronchial tumor and there is high risk of bleeding, then we can use that too. Apart from that, which we have been stressing upon since the start of our panel, that we should always be prepared for any bleeding complications, and everything should be kept handy so that any untoward complications like disastrous bleeding can be maintained.
Right. So, Dr. Ajay, what about doing a biopsy if the patient is hypoxic? Do it or not do it, and if do it, then what precautions to take?
I think one of the very important questions of this session itself, because we may be dealing it on a daily basis, because some of our patients we deal with maybe hypoxic COPD patients, or sometimes we may be called up into an ICU to get a biopsy. So the basic practices, the basics remain basic, which means that the basic safety precautions has to be maintained. First is that it starts from the pre-op assessment of the patient itself. So when you start their assessment, you should make sure that the patient, the indication is very clear, because if the biopsy has to be done, whether it can be avoided, whether it has to be postponed, there is something which can be optimized, then you may postpone the procedure for a few times so that hypoxia settles in. But if it is emergency and if you have to go through, then you have to go through with extra precautions. Herein we have to make sure of the severity of hypoxemia. Also, it's better if you have a ABG in hand, so that you see that whether it's associated type 2 failure, which can worsen if you supplement so much of oxygen during the procedure. Also, other cardiac comorbidities, even COPD, all these things has to be noted down. And once you before you start the procedure, the monitoring facilities for basic bronchoscopy, you will have a cardiac monitoring, ECG, as well as oxygen saturation. But when you are dealing with hypoxic patient, your suit, it is better that suit is equipped to be converted. You have a backup HFNC, something like that, or if an non-invasive ventilation support, or even a ventilator support if required during the procedure. If the patient decompensate, you may have to increase your oxygen from a nasal cannula to the mask, or an HFNC, or an IV, or in worst case, you may have to change it to a intubation and ventilation. So you should be prepared for that. And anesthesia, you have to be careful. You should not oversedate. Minimal sedation. Oversedation should be avoided. And when you go into the procedure per se, you have to minimize the time of procedure. That is the most important thing which can do. You go in as quick as possible, come out as quick as possible. Limit the time of the procedure inside. Limit the number of biopsies to the minimum required for your diagnosis, whatever is. And also, one important thing is that you limit your suctioning, because suctioning again is going to take away the oxygen from the patient as well, not just that. So limiting the suctioning, minimal suctioning as required, and minimal sedation and minimal procedure time is the most important things which has to be taken care of when you're planning to biopsy hypoxemic patients.
So this is the last question from our side, basically, and I would only like to congratulate each and every panelist this evening and share with them that we have almost 2,200 logins this evening, which is like a record number to have. And it's all because of the interactive session and the kind of education and the insights that you people are giving to all our audience today, that they're really very excited and have posted lots of questions here with us. There's a lot of excitement, a lot of questions. So let me start with the first question to Dr. Vinny, that what are the contraindications for bronchoscopic biopsy? Vinny, you've done that earlier also, so can you just repeat it, please, quickly? Contraindications to transbronchial biopsy.
So absolute contraindications and relative contraindications. Absolute would be no consent from your patient, malignant arrhythmias, uncontrolled coagulopathy in your patient, and a recent MI, which means recently, within weeks, previous weeks, the patient has had MI. The relative contraindications would be uncooperative patient, uncontrolled arrhythmia, which is not malignant, uremic patient, wherein the patient is on dialysis, certain kind of patient where the patient is having hypoxemia or respiratory failure, wherein the requirement for oxygen is something like more than 3 to 4 liters of oxygen per minute. So these are some of the contraindications and relative contraindications.
So this question was asked by Dr. Jai from Delhi. We have another question now coming to Ankit from Dr. Rashid from Kanpur, that how would you manage bleeding while doing a TBLB, EBB and TBNA?
Sir, as rightly discussed,
Just tell us quickly all the steps.
Yes, we have discussed various modalities. So again, during the procedures, rigid bronchoscopy is a good option that we have, because it will help in that particular case. You have certain handy Fogarty catheters and blockers that could be useful in that particular case of controlling your bleeding. Particularly transbronchial lung biopsy, we can pre-hand do a Fogarty catheter insertion before taking biopsy sample, because that will save time. And just recognize if your patient is hypoxemic, don't just go for intubation and ventilation to secure your patient. and again, bronchial artery embolization in selected cases.
Right. So, Dr. Ravi, Ajay Ravi, Mangesh from Nagpur wants to know that what is the role of ROSE in biopsies? Do you do any
So,
rapid on-site evaluation for these patients?
so yeah, ROS, if available, is always a very helpful thing for the pulmonologist because we can ensure that our yield is better and yield of the procedure. So we routinely do. We don't have a pathologist coming to us, but we do ROS. We do epi-ROS actually from the pulmonologist, but mostly for the EBUS samples. For the endobronchial biopsy samples, also you can have an imprint cytology and you can use the same stain as you use it for an EBUS rows. And if you especially for for a bronchoscopically visible lesion, this is not of much help because, but at least you can get a early make it sure that it is a diagnostic, not just necrotic cells if it is necrotic lesion. But for bronchoscopically invisible lesions, the peripheral lesions, when you go for a TBLB and all, your imprint cytology with a rose will be helpful, which makes which helps that which tells us that you have hit the lesion because we may hit out. And this is more important when it comes to peripheral pulmonary lesions and all, wherein where you look at it with a ready libus and take a biopsy and you make sure that you hit the right amount of lesions. For TBLB also, it will be helpful. Anyway, it will be helpful. But we can get an imprint cytology and that yield adds to our yield of the procedure.
Right. So we've got some very good comments and very good appreciation also that excellent insights shared in the presentation truly added value to our understanding of bronchoscopy. Thank you for your kind words. Ajay from Chennai wants to know how to handle bleeding post endobronchial lung biopsy. I think we've just discussed that. Now coming on to another question from Dr. Akif from Akola. He has lots of queries. I think most of that we've touched upon already, but I guess we'll just repeat it for his benefit. Starting from Dr. Tale, that what are the indications of a bronchoscopic biopsy?
But the main indications are to diagnose lung cancer and to know the etiology of interstitial lung diagnosis, interstitial lung diseases after we send every workup, and to know about the etiology of the different chronic infections like tuberculosis, fungal infections, etc.
So, Dr. Ankit, how would you choose that whether you do a TBLB or a cryobiopsy? Of course, EBUS, TBNA, and TBNA don't fit into this discussion. But TBLB and cryobiopsy, which one would you choose in which situation?
Sir, again, it depends on the center, how much it is equipped, if we have a cryobiopsy already available. But again, we have to see how vulnerable our patient is. If he has coagulopathy, then we definitely would like to have a safer alternative to our patient than the cryobiopsy. But if the modality is available and your patient is a candidate for it, we definitely go ahead with the cryobiopsy for that patient.
Right. So, Winnie, what pre-procedure investigation would you do in your patient?
So the basic investigations which would be required are CBC, KFT, LFT, just to have a look at the profile of the patient, and also an ECG to have it as the least amount of assurance that the patient is actually who's coming to your suite is normal. Also PT-INR and APTT to get yourself safe from the litigations which are very high on these days. So you should be checking the coagulation even if the patient is not on anticoagulation. If the patient is on anticoagulation, of course, you have to check the PT-INR and APTT before you go in for any kind of procedure like bronchoscopy. If your patient is a high-risk patient, you might also requiring 2D echo, especially for the diastolic dysfunction which the patient might be suffering from. And when they lie down in your suite, they have orthopnea, which can cause the additional hypoxemia which the patient might undergo when they have these kind of procedural procedures carried out on them. So these are some of the basic investigations you need before you go in for the bronchoscopy.
And just before that, you've already highlighted all the contraindications, so I guess we can skip that now. But is there any way of assessing the bleeding risk prior to a biopsy, apart from doing these routine blood tests, PD, PDT, coagulation parameters, uremia? Those are the only things. Anything else, Dr. Winnie?
So bleeding is something which can happen in any of your patients. So benign looking lesions, which are very, very, kind of benign looking on your endoscopic view, might sometimes bleed to death. So this has been seen, but there are some modalities which you can use in your bronchoscope, wherein the color of the lesion tells you if it is a highly bleeding lesion. So that comes in as a setting in the bronchoscope, which are the newer bronchoscope, wherein you can see if the patient is having any kind of additional bleeding tendency. If you're suspecting a carcinoid, especially in a patient, which are certain kind of investigations which the patient has undergone, or your radiologist has told you that there are high chances that this might be a carcinoid, then you should be prepared to handle this kind of bleeding and go in for a rigid bronchoscopy preemptively. So that is something which you should be doing.
Right. So Dr. Rashid has sent us compliments. He says it's a great session, concise, scientific, and clinically very relevant. Dr. Gaurav would want to know, Dr. Talia, from you, that what is the risk of pneumothorax with TBLB?
So the risk is generally around 2 to 4%, and the risk increases when the patient is having concomitant COPD or lung cyst. So generally the risk is around 2 to 4%.
Right. So Dr. Jayesh from Solapur wants to know about the role of ROSE in EBUS. Dr. Jayesh, this webinar is actually on basic bronchoscopic procedures and not on EBUS. Yet, since you've asked a question, I'll ask Dr. Ajay Ravi if you would like to answer this. That what is the role of EBUS in what is the role of ROSE in EBUS TBNA? When should TBNA be preferred over when should you do a transbronchial needle biopsy over aspirate alone?
So, regarding EBUS and ROSE, we have several papers when we compare the ROSE. So, what we say is that if you are doing a conventional TBNA, the ROSE adds to its value, and the diagnostic yield is significantly improved when ROSE is added with a conventional TBNA. With an EBUS TBNA, ROSE may not be increasing much of your diagnostic yield, but ROSE reduces the procedure time as the number of passes that has been shown. And this is more, again, EBUS TBNA, it is more particularly important when you are doing a staging EBUS, wherein you start with an entry node, then you go to an N2 node, then you go to an N1 node. So suppose you don't have a ROSE in your suite, and if you have 10 nodes in all these stations, you may have to sample all these 10 nodes separately and send it to your pathologist separately as 10 different stations, and they have to stage it. But if you have a pathologist and doing a ROSE in your suite, you sample the first entry node, and if it turns out to be positive, your staging is done. You don't need to sample your N2 or N1. If N3 is negative, you go to your N2. So then if N2 is positive, you don't need to go to your N1. So this is staging EBUS ROSE is extremely important, but increasing the diagnostic yield is not of that much helpful. When it comes to conventional TBNA, it helps again. And it reduces your time, and it reduces the number of passes.
Dr. Mangesh says that it's highly engaging and informative, appreciates the depth and clarity brought by all the panelists. Thank you, Dr. Mangesh, for your kind words. Dr. Omkar from Jaipur would like to know that what should be done in case of coughing mid-procedure. Dr. Vinny?
So mid-procedure, if your patient is coughing, what we do is spray as you go. So once you give that local anesthetic spray, usually this kind of coughing subsides. However, if you're in a procedure where you're taking a biopsy, you can ask your anesthetist to give additional doses of propofol or fentanyl or midazolam, whatever anesthetic agent they might be using. Also, we have a study, a randomized control trial from All India Institute of Medical Sciences, which says that the intratracheal instillation, transtracheal instillation of 2% lignocaine at the initial part of your starting your procedure as compared to spray as you go technique is a very good modality to reduce the number of coughs and the procedural comfort for the patient as well as the person who is doing the procedure is considered to be higher. So intratracheal instillation is very good method wherein we have seen less number of cough counts when we do these procedures for patients.
So Dr. Ajay from Chennai wants to discuss about EBUS TBNA, which I think we'll skip because We still have a lot of questions to go in this session itself.
Just to add to that previous question, can I interrupt?
Yeah, sure. Please.
Yeah, so it's about coughing. So spray as you go, as Dr. Vinny rightly said, that it is helps. But one other thing which we usually note is that once you are in, most of the cough is from the upper airway. So if you are not properly anesthetize your cord and your larynx before you enter, how much you give the spray as you go inside your airway is not going to, because many a times we have noted that it is not from the airway which is generating the cough, it is from the cords or above which is not properly anesthetized. So you giving your spray, 10% lidocaine spray, then anesthetize the cord properly before you start itself is very important. If that is not done, the patient will keep on coughing how much you give inside. So that is one thing which has to be very clear.
So, Dr. Manisha, you told us about the surgical lung biopsy versus TBLC, that there's not much of difference. But Dr. Omkar, for your own town, Jaipur, wants to know that what are the advantages of TBLC over TBLB?
Okay. When we compare transbronchial lung cryobiopsy with the transbronchial lung biopsy, the main difference is that the tissue size, which the sample that we get from the transbronchial lung cryobiopsy is definitely larger, and it is well preserved. The architecture is well preserved, and there are fewer crush artifacts when compared with the transbronchial lung biopsy, where the sample size is comparatively very small and a lot of crush artifacts are there. So these are the main advantage of TBLC over TBLB. We get a definitive diagnosis with TBLC because the yield is also very high, approaching around 80% in this process.
So what is the minimal acceptable sample size for diagnosing ILD on biopsy? Dr. Manisha?
The minimum acceptable sample size for diagnosing ILD on if we take the transbronchial lung cryobiopsy, the sample size, as already explained by Dr. Ajay Ravi sir, that around 5 mm it is there, and it is enough to get the diagnosis. However, in case of the transbronchial lung biopsies, the sample size is smaller, and 1 to 2 mm size would do for the diagnosis of ILD in this biopsy.
Right. So this was a question from Dr. Jayesh from Solapur. He also has other questions on how it should be processed, what staining should be done. I think that we'll have to have a separate session by a pathologist rather than us. But coming back to Vinny, that how should the biopsies be transported for microbiological evaluation? At what temperature should they be kept?
So as we have discussed this earlier also, we should be transporting the samples to the laboratory as soon as possible. However, if you're anticipating a delay, you should be storing these biopsies in a container in the refrigerator at 4 degrees centigrade. So that is something you should be doing. Also, collecting the biopsy in the right kind of container is very, very important. Your microbiological samples, which have to go to the microbiology lab for viable tissue, because the organisms would be viable in that tissue, you have to keep it saline only. For the ones which are going for histopathology examination, they are to be sent in 10% buffered solution of formalin to the histopathology lab. Also, the ones for molecular diagnosis go in the same container, which is the formalin solution. However, ideally, they are to be frozen in liquid nitrogen. However, this is not present in every center. We also do not have it at our center. We only send the formalin fixed tissue for molecular analysis as well.
Dr. Tale, Dr. Gaurav from Mumbai would like to know that what are the alternatives to bronchoscopic biopsy?
The alternatives are ultrasound guided biopsy. When the lesion is close to the chest wall, we can do CT guided biopsy. And some ILDs, rarely we perform surgical lung biopsies.
Right. So Dr. Omkar feels that it's a very well structured session with valuable perspectives. Thank you to the speaker and panelists for the enriching inputs. Unfortunately, nobody has praised the moderator for this evening, but I still continue doing my dirty job.
It's coming, sir. It's coming.
It's coming? Okay. Thank you. Some hope, huh? Okay. So Dr. Aslam wants to know the step-by-step of introducing the Fogarty catheter before intubation. Dr. Ajay Ravi, please.
My practice, I usually do the TBLCs with the rigid bronchoscopy alone. I don't do it with an ET tube. So if you are doing it with a rigid bronchoscopy, it is passed through one of the accessory channels. As I said, I do it through the jet ventilation port, wherein you can keep it placed and that will be stable there. But as Sir said earlier, If you're doing it with an endotracheal tube, there are two options. Either you go through the ET tube or you go parallel to the ET tube. So if we are planning to go parallel to the ET tube, you may have to insert it first through the vocal cord under direct vision, maybe with a laryngoscope with the anesthetist may help you, or you can hold it with your bronchoscope with an forceps outside and just hold it and keep it and place it into the whichever side or segment through a bronchoscope, a forceps coming out of your working channel and holding the Fogarty on Fogarty parallel outside the working channel out parallel to it, and you can place it. But usually when they do it, your anesthetist can help to pass it through the cord, and with your bronchoscope you can just manipulate it to which of the segment which you require if you're doing it outside the ET tube. But inside the ET tube, you may have to restrict your working channel because the size of the channel again reduces if you pass two things through an ET tube. But rigid bronchoscopy, it is easy that everything will go through the single channel.
So Dr. Jayesh from Solapur would like to know that when is EBLB preferred over biopsies? Dr. Ankit?
Sorry, sir.
Jayesh from Solapur wants to know that when is EBLB preferred over other biopsy methods? Probably not a correct question. But how is EBLB performed during bronchoscopy? Okay, let's do that.
Sir, again, after proper sedation and pre-evaluation of your patient, obviously you have to localize the lesion which is there at which particular segment the involved lesion is. Then you have to through your working channel, you have to proceed your forceps, as rightly said by Dr. Ravi in his presentation. That is, it should be below the nose, and you have to grasp your lesion, and you take a biopsies, and then you have to come out, and then you have to see if there is any bleeding happening. Then you have to make all the measures to control the bleeding.
Right. So Dr. Gaurav from Mumbai says there's a great synergy between the moderator and the panel. Made session highly engaging and exciting. I'm so happy to listen to that. Okay, Dr. Jayesh, in a wedge bronchoscope after biopsy, how will you come to know if the bleeding has stopped? Well, you don't have to. You just leave it there for 3 to 4 minutes and then gradually withdraw it and see. In all likelihood, it would have stopped. If not, and you're just gradually withdrawing it and you realize it's still bleeding, then just push the scope back into the same segment. Do not move it very far from the main segment. Dr. Gaurav from Mumbai likes to know that how does lesion location influence choice of biopsy? What are the predictors of bleeding risk? This we've covered already. What is the role of one lung ventilation in massive bleeding? Well, if the patient is bleeding, you have no choice but to do a single lung ventilation. So there are two reasons. One, you prevent the aspiration of blood into the other side as well. And second, that patient's oxygenation will be maintained. And does IV tranexamic acid help in this situation or not? As a pre-procedure, it is not recommended. We don't even know whether it works post-procedure or when the bleeding occurs, yet we do use it. There are no very large-scale trials which say use of tranexamic acid will help in controlling the bleed, but yes, you can use it and we do it. Then Dr. Kumar from Surat wants to know what are the emerging techniques improving biopsy accuracy. So basically, there is no role for rigid here when you're doing a biopsy. If the site is easily accessible, then all you need to enhance your yield by using a radial EBUS, by imaging techniques, where you can use fluoroscopy, or you can even do a cone beam CT, or you can even do a navigation bronchoscopy. You can improve your yield using all these things. Dr. Kunal wants to know how to sedation and anesthesia impact biopsy procedure. So basically, why I'm taking all these questions in this, now we hardly have any time left, so I thought I'll quickly answer all these for you. That sedation and anesthesia do not impact the biopsy procedure, but they provide you a better compliance with the patient. When the patient is properly sedated, you're able to do the procedure calmly, quietly, and control the cough as well. Excessive coughing can result in pneumothorax sometimes, especially when you're doing the biopsy procedure. But at the same time, you want the patient to be complying to what you're saying. And so the sedation has to be just moderate and not deep. What complication can arise from bronchoscopic biopsies from Dr. Mangesh? Two basic complications that you should be prepared for: pneumothorax and bleeding. Can you explain about endobronchial mass biopsy in pediatric patients and endobronchial bleed control? Bleed control we've dealt with already, Dr. Vijay. And as far as endobronchial mass biopsy is concerned, you have to be very, very careful when you're dealing with these masses, which can bleed excessively. So what our policy is, at first we take a brush from the surface and see if that bleeds or not. If it doesn't bleed, then we put in a TBNA needle into the biopsy, into the mass, and see if it bleeds or not. If it still does not, then only we introduce the biopsy forceps and take it. But please remember, even then, sometimes the bleeding can happen. If it is in the main trachea or around the carina, avoid touching it without a proper backup. Because if it starts to bleed, then there's no way you can control it. And you may just lose the patient on the table. If it is in any of the lobar bronchi, then yes, you can consider it, but have all your tools ready, like the balloon ready, the cold saline ready, only then. Dr. Neeraj wanted to know what are the contraindications to TBLB. Dr. Vinny has already explained it 2 or 3 times. I think there's no point repeating it again. Probably you could have the recording later on. Dr. Manoj from Gujarat wants to know how do you prepare a patient for bronchoscopic biopsy? Again, Dr. Vinny has dealt with it at quite a length. Can TBLC improve diagnostic yield in ILD? Dr. Kundan from Pune wants to know, well, if you're doing it for diagnostic purpose, TBLC is definitely preferred over a TBB. I think rest of the questions by Dr. Omkar have already been handled by Dr. Manisha. What is the role of fluoroscopy guided TBLB is asked by Dr. Mahesh from Bangalore. Role of fluoroscopy basically increase the yield by enhancing your localization of where you're taking a biopsy from. I think these are just the questions. Rest are all repetitions that we've already answered quite a few times. So with those words, I think we'll really like to bring this to an end now. We have passed our scheduled time and we've covered all the questions again and again. Despite all that, this webinar will be available to you on the YouTube. There will be a link that will be circulated. You can still go through it again. And still, if you have questions, please write to us. Please write to IAB and we'll be more than happy to help you with the answers. So thank you so much, all of you, for joining in this evening. Dr. Tale, Dr. Ajay Ravi, Dr. Vinny Kantru, Dr. Ankit Bansal, Dr. Manisha Jain, for a very insightful, exciting, and educative session this evening. I myself have learned so many things from all of you. And it's really been a pleasure to have you on this panel. I'd like to thank Dr. Amita Nene for giving us this opportunity, IAB for scheduling these kind of webinars, which were never known to happen till about 2 or 3 years back, and now they've become a regular feature. And thanks to Amita for taking this lead role